the best lessons I learned on CTO during the past year, and these lessons, literally, I learned from talking to others, okay? Like when we meet, over beer and over wine and lots of it, we basically discover each one of us what he or she is doing. So I came to use more Astato and Hornet 14 and Bove, what we call transcatheter electrosurgery. This is, I think she's 55 years old, very diabetic, very poor distal targets, very heavily calcified LAD. So this is how the procedure went. We thought it's short occlusion. The vessel was actually reconstituted all the way to that chunk of calcium you see there. So I thought, I'm going to go antegrade. We put a microcatheter, and this is how it goes. I already used the Confianza Pro 12, then Pilot 200. Then I said, okay, there is no way I could puncture this proximal cap. Astato 20 gram tip, 0.009, Pilot 200. Astato 40 gram tip, Pilot 200, then Gaia third. And actually, I was able to cross it. I had to rotablate it, nothing will go. Then this is after rotablation, this is how much calcium. These are the results. So what are they? Astato XS20 and Astato XS40. And I think these wires are approved for the peripheral. This is not approved for the coronary. Again, this is not approved for the coronary, so for the FDA in the panel, in the audience. But when you have to be successful and be safe, if you know where to poke, you can use them. Another problem we face with calcium is you do an ADR, antegrade dissection reentry. You set up, you have a very good distal vessel. Look at the big LAD here. I thought I'm going to puncture it. I punctured, and I thought the wire is in the true lumen, but I couldn't kind of puncture and drive. So I put a Pilot 200, and this is what I found. The Pilot 200 just besides the LAD. So I just learned that actually Astato is good for calcium. If you notice, this is the Astato. Unfortunately, I don't have the puncture movement, but I actually added a secondary bend in it, and there you go. We punctured, and now we have the Pilot 200 stick and swap. So this is another lesson I learned last year. This is the final LAD picture. So the Stingray is a 12-gram tip wire. It's a pre-shaped 1 millimeter. There is a barbed wire at the end of it that actually frequently is damaged and it doesn't work, and you can't use it. So now a lot of operators are moving to Hornet 14, which is 14-gram tip, and it's tapered to 0.008. And Astato S20, which is 20-gram tip, and it tapered to 0.009. I have not used Astato 40 yet. So what if Astato is not enough? This is actually a stented CTO. This is a left main stent into the LAD, stented the circ shut. And this is a failed cabbage to the circ. So what to do here? This is a baseline. We went retrograde epicardial collaterals through SVG to the RCA. And now we kind of trying to go retrograde. The worst thing you can do with retrograde wire goes outside the stent. You have the more you try, the bigger the space. You can puncture into the stent again. So this is how it goes. I have retrograde Xi'an blue that actually crossed the collaterals. Gaia third, because that's very directional. Pilot 200, because I had to knuckle closer. Then I went back to Gaia third, tried, wouldn't go. Then I tried Confianza Pro 12 antegrade, Pilot 200, Astato 20, Astato 40. And then you have to resort to really extraordinary measures. Confianza Pro 12 with a Bove at 50 joules. This is unipolar, similar to what we use to puncture from the IVC to the aorta. Then it didn't work, so I went Bove 70 joules. Then I went back again, 70 joules Bove. And then I tried actually a little bit to go and with a Gaia third, and here the Gaia third going right, cross, and using the retrograde wire. So what I think the Bove did is actually soften the plaque so I could cross it retrograde. And it was successful. I had to use rotablation, as you can tell. This is the final result actually after 2 procedures because he has another CTO of the OM, and I have to actually do it in a separate procedure. So Bove wire setup, this is how you set it up in the back. This is Bill Nicholson. Basically, he virtually invented this. And you hold the Bove with the wire, the back of the wire with the hemostat, make sure nothing wet, and then you go. And more than that, Bill Nicholson is actually using the Bove to re-enter for ADR. So I have not done that yet, and hopefully that will happen soon. You still fail. This case, I have antigrade 40 Astato, 70 joules didn't go, and retrograde 40 Astato, 70 joules didn't go. And finally, what we had to do, we went around the stent because it was a fracture stent and did it. We took a little bit detour around the old stent. In conclusions, wire with higher penetration power can be used when anatomy is known. You have to know where you're poking. If you don't know the anatomy, do not poke unless you have a CT like Farouc. Transcatheter electrosurgery is coming on the horizon and hopefully going to be used more and more. And there is just a report in JACC about bipolar, both wires kind of creating an arc. If all failed, you really have to be creative. Thank you so much. Any questions? Yes, Wissam.
Great presentation, Cal. I find myself using more and more Astato 20 to re-enter with the Stingray. Should it be our go-to now wire to all re-entries with the Stingray balloon? Is that what you guys are doing?
Yeah, I think the Astato is, because the enemy of the re-entry is the calcium, and basically the Stingray wire slides off the calcium, and you can't puncture. So you have to ensure puncturing. And I think that I just talked to the Stingray wire is made by Boston, trying to convince them to do it 40-gram tip Stingray wire, or at least 20-gram tip. So that's actually coming. Yes, Manos.
So Carl, that was phenomenal prescription. I think a lot of excitement both for the Astato and for the electric re-entry. Now, for people, what I guess you should say, make sure 100% before you do this, you know where you're going. Because if you burn a hole in a place that's the wrong place, it's a problem, right? So number one. Number two, people are asking, why don't you get the back end of the wire and push it? Have you ever done that, or do you recommend it?
I did it, but it did not work because you can go in a subintimal. The problem with the back of the wire, it's changed the anatomy. When you push it in, it's so hard, it changes the anatomy. It straightens the segment you go into. So if you are talking about an osteal disease, or very proximal disease where you don't have a tortuosity, and it might damage the microcatheter when you push it through. I've done it a long time ago, and it didn't work back then, but I was not actually a CTO operator back then. I was in 2006. So it's a great idea. I might do it. Did you do it?
Well, so I've done it, unfortunately. The problem is it's very hard to see because the front end has a radio-opaque segment, the back you don't. So actually, I say most people don't do that because it's hard to see and you may go to places you don't want to go. But I think for people who don't want to go extreme, so to speak, Hornet 14 is the stiffest wire from the quote-unquote coronary wire. So Hornet 14, Confianza Pro 12 still remain good choices for this group. But I love the technique as well.
Thank you, Manos.
Cal, was there a microcatheter on that wire when you Boved it?
A microcatheter? Or was the wire relative to the wire when you're Boving?
Oh yes, you have to put a microcatheter, and you have to pick a microcatheter with insulation, because if you're not, the electricity would not be concentrated in one spot, or you have to have an insulated wire. So I use actually, first time I used the Kervil, it's actually melted the tip of the catheter. So now I use either micro 14 or fine cross, because they are plastic and completely insulated. The other metal wire catheters might not work. That's what I think.
Yeah, Bill Nicholson comment on that. We had one case, and we could not get it to work with a Corsair, but it was able to work with a Turnpike. So, and I think he's described Turnpikes being used, but there is, we really need to understand these insulating properties of each of these microcatheters.
Yeah, it's electricity. So if you don't, if it's not insulated, it's going to dissipate through the whole tissues. And I think the Turnpike. And they have coating in the inside, so that's why they sometimes work. But if you abrade, like if the coating is gone, you'll not really be able to kind of have that unipolar electricity concentrated at the tip.
One last thing, people have seen the plasma wire. So Japan, there is a new system where it has two wires and they make essentially an arc of electricity through this, several thousand volt. Now, can you do this with your technique? Get two wires and make them connect in a reverse card or otherwise?
So it's a difference between unipolar and bipolar. So it's a different settings. You actually can do that. Like Kato and his team did 7 cases in Japan. And I was surprised. It took them like, there are 2 cases they almost failed. And I think their concentration, I think what we need to think the next step is to facilitate re-entry. And when you have calcium, basically sometimes you can't, but I think we can do it. But we just have to figure out the setting on the Bove machine.
So just a quick comment. So I actually happened to be visiting Bill when he did one of these cases, and he just published it. So I told him he should call it the electric stingray. I think that's right. So the stingray and then use electric.